started here, recording. All right, so welcome everybody to the virtual Rehab Summit. And I am so happy to introduce Dr. Dustin Jones and Christina Prevett. Am I saying your names right?
Yep.
All right, pretty simple. And so let me just start with a little bio on both of these people, and then I will turn it over and get out of the way. So first of all, Dustin is a physical therapist and board certified geriatric specialist. He also has a background in sports and orthopedics. He received his doctorate of physical therapy in 2011 from the University of Kentucky. Dustin is a board certified geriatric certified specialist, GCS, and CrossFit level 1 trainer, CF-L1. I guess if you see those acronyms, you'll know what they are. He blends his sports and geriatrics background to help older adults improve their lives at Stronger Life in Lexington, Kentucky. He teaches the modern management of the older adult curriculum with the Institute of Clinical Excellence alongside Christina Prevett. Dustin is also the creator of Geros, am I saying that right? Gero Health, which has been a key voice in shifting attention towards elevating the quality of care and more specifically, the intensity of care that we deliver to aging adults, that they deliver to aging adults. All right, a little bit about Christina. She finished her Master's of Physiotherapy at McMaster University, graduating in 2013. She is a believer in the strength of exercise for rehabilitation, especially with older adults. This passion led her to begin her PhD in 2015 in the Faculty of Health Sciences at McMaster University under the supervision of Dr. Ada Tang. Her doctoral studies look at the utilization of strength training principles for healthy aging and prevention of disability. She obtained her Certified Strength and Conditioning Specialist, CSCS, accreditation through the National Strength and Conditioning Association. You may know them as NSCA in 2014. She interned at McMaster University in Strength and Conditioning. He was a member of the medical staff at the 2015 Pan Am Games in Toronto, Ontario. Is that right?
Yeah.
ON? Yeah. Christina teaches internationally on physiotherapy and exercise for the older adult. Her course, Modern Management of the Older Adult with Dustin Jones through the Institute of Clinical Excellence, helps therapists provide quality care to their older clients. Christina is a mom of Maya, a fur mom of Boomer and Bailey, and is a national level weightlifter competing in the 64 and 71 kilogram weight classes. So, wow, I think you guys are in for a great presentation. Welcome, and I will turn it over.
Excellent. All right, let me share this screen. Hello, everybody. I'm gonna hit presenter. Thank you so much for inviting us. Dustin and I are super excited to talk to you today about 1 rep max living. The nice thing about the two of us doing this presentation together is that we want to make this session as interactive as possible. So if you have any questions while I'm talking, Dustin will probably be monitoring the chat box and opening up some conversations. And we'll swap when we do a brief computer switch where we switch slides so that the other person can take the lead. So we kind of did some of our bio. One of the other things that wasn't mentioned because it was on my site is that I also own a physiotherapy gym hybrid model. So you've probably heard me talking in the panel discussion around innovative models of physiotherapy care, integrating fitness-based components to our business model. But here's some of our pictures of me and my hubby and my baby and my fur babies. And here is some of Dustin's kind of photos around different areas of his life that they mentioned in the bio. If you guys are looking for more information, we said that we are faculty members for the Institute of Clinical Excellence. We teach modern management of the older adult to physical therapists, occupational therapists, and fitness professionals. And these are some of the hashtags that we use as we start trying to inundate social media with as much geriatric content as we possibly can to make it the cool place to be in the fitness and PT space. All right, so through our presentation, you are going to see this beautiful image of the ankle pump. And sometimes we know with virtual summits, it can be really tough to stay engaged with these things when there's so many things happening around you. So anytime you see the ankle pump, we are going to do a 30-second sit to stand test. This is a geriatric outcome measure that is used very often to take a look at functional strength in our older adult clients. And we're going to use it today as a bit of a fitness piece. So we can't see you all, so we're going to trust that you are doing this. I am about to set my timer to 30 seconds. We're going to do a practice run, and each time you're going to try and see if you can match your score, but don't dog it. Don't dog your first one. I'm going to set this timer. We're going to try and be interactive, and we're going to start in 3, 2, 1, go. I feel like Dustin's dogging it. I'm watching him. I can't see anybody else, so I can only chirp you. All right, halfway. Good, keep going. 5 seconds. 3, 2, 1, and stop. Good. All right. I'm going to try and keep lecturing while also doing intermittent intervals of squatting. We are going to try and do that every single time, because one of the great things about speaking to this crowd is that fitness forward is your ethos, right? Like you guys are fitness professionals. You believe in the power of strength training and exercise in general for older adults. And so we're going to be about it in this lecture today. All right, where are we going? What to expect? So what is 1 rep max living? How can we identify it? And what can we do about it? And so the best way of doing that is by giving you a bit of an example. So what is 1 rep max living? So we are physical therapists. Oftentimes, one of the main reasons why people come to see a PT is because they're in pain. So you have Gare Bear here. He is coming to you because he's got an acute onset of low back pain. So you get working with him. You try and bring that pain down with whatever techniques you're using. You start transitioning into an exercise program to try and get him stronger. And he comes into your clinic and he is doing well. So you're like, yes, this is great. This is exactly what I want to see. You're doing awesome. And then what do? You discharge him. You're like, you're doing great, Gare Bear. Awesome working with you. Have a good life. Keep being strong. Take it easy. So Gare Bear goes back. He's finally feeling really good. And he's like, man, I have had this back pain for a month. I have not done laundry the entire time. I need to get this down to my laundry room. I'm going to take this big load of laundry and I'm going to take it downstairs. The laundry basket is probably about, let's say 16, 17 pounds. It's heavy laundry. And he is responsible for bringing it to his laundry room. He's got to pick it up. So he's doing a deadlift to pick up that laundry. But what we're seeing is that the max that he can deadlift is close to that amount. So sorry, let's say that the laundry basket's 15 pounds. His max deadlift is 16 pounds. Now, what would you consider that in regards to effort? Would you consider that something that would be easy breezy and he would be able to do that over and over again? Or would that be something that's extremely taxing on his system? The answer is it's probably pretty taxing because he's working at a fairly close to his maximum effort. And that is what we call 1 rep max living. And that is when the demands of your life are near or exceeding your capacity. So things that for you are getting up off of your toilet seat, for some of our older clients, especially if you're working with them in the home, or if you're going into something like a skilled nursing facility, you're probably maybe getting them to do a 1 rep max squat by trying to get them to stand up from an elevated surface. And so we've had a ton of literature that has looked at the capacity that older adults have and trying to measure that relative to younger peers. And this study was really interesting because what it did was it compared the relative effort the percentage of joint movement relative to max joint movement, essentially effort, to execute activities of daily living in older adults compared to younger adults. So they took individuals who were average age of 22, compared those to clients who were average age 74, and looked at the relative effort. And what it showed was that to go up a flight of stairs for a healthy community dwelling older adult, they are oftentimes working at 80% effort, to go downstairs 88, and sit to stand at 80%. So really let that sink in. If you have done an exercise program where you have done a bunch of squats at 80%, you are tired. You do not want to do endless amounts of sets of those throughout your day. And that can sometimes be our clients' day-to-day context. And that really shed a lot of light for me around why it is so important for us to be working on strength training and heavy strength training relative for our older adult clients. And so this is getting into the concept of resiliency. How resilient are our clients? And the first question is, what is physical resiliency? And this is a characteristic which determines one's ability to resist or recover from functional decline. We are in the world of COVID-19 right now. If we have a client who has low physical resiliency, who comes down with respiratory complications of COVID-19, are they going to be as able to recover from it versus somebody who isn't? And therefore, I think this has been a really important conversation that is coming into the literature and is coming into our conversations as fitness and health professionals, because we are going to be seeing people on the other side of COVID-19 who are going to need our help. And this is where we start to see differences in our older adults' functional trajectories. And so here is on the y-axis, you're seeing a person's physical function, and on the x-axis, you're seeing age. And what we can expect from normal aging physiology is that we're going to see a decline in physical function throughout the course of a person's life. And we're going to have dips up and we're going to have dips down with sickness, periods of immobility or sedentary behavior, just different components or phases in a person's life. But what we're starting to see is that as our clients get older, they start to reach the point where their functional capacity is at or maybe slightly below the level of a demand for activities of daily living or basic tasks around the home. And that's a really dangerous place to be in, because that means that there is one thing that can happen that can either flare up musculoskeletal pain, which can be Gare Bear's incidence of low back pain, picking up a laundry basket that's too heavy for him. It can also threaten their ability to be independent in their home. And that is huge, where the reason why a person is sometimes transitioning into long-term care or an assisted living facility or nursing home is because they're not strong enough to get up out of a toilet seat or off a toilet seat and they're falling in the bathroom. This is low physical resilience, and it determines one's ability, again, to resist or recover from functional decline that follow a health stressor. And that could be the flu, that could be an exacerbation of chronic condition. There are so many different things that can highlight a person's resiliency in their capacity to recover from that, that we see in our day-to-day interactions with our older clients. Contrast this to reserve. Sometimes people will use these two terms synonymously. And when we're talking about reserve, we're talking about the system's physiology. So this is the capacity of the cell, the tissue, and the organ system to recover back to baseline. An example that we see in healthcare is individuals with diabetes who go under general anesthetic. Sometimes if their blood sugar isn't regulated very well, it can take quite a long time for them to be able to get their blood sugar under control in the acute care setting. Those are individuals who have really low physical reserve. And so let's really consider this 1 rep max living situation. When we're thinking about a person who is getting to this point of 1 rep max living, what we need to remember is that these are individuals who have lived their whole life, maybe for some people who are younger, taking for granted how easy it is to just get up out of the toilet or transfer into and out of the bathtub. And so they're really thinking about, you know, the life that they had before. And as we get older, sometimes people experience this as a series of losses of ability to do things, losses of confidence from their family members that they can do things. And this decline starts to, you know, from this community dwelling older adult, we start to see that sedentary behavior starts to increase. We have individuals who may be experiencing this almost depression and isolation because of their inability to be able to do the things that before they did no problem, or they're starting to feel like they don't want to ask for help, even though they're really struggling to do some of these day-to-day tasks. And unfortunately, ultimately, it ends up in situations like this where individuals are in assisted living facilities and spending a good portion of their time in sitting or wheelchair bound because of their inability to do functional tasks, including walking independently down a hallway. And so when we have these things like weakness and deconditioning and stiffness, things that we have the modalities to fix, that we know what we can do to make this better, what are we doing? Adductor ball squeezes, AKA underdosed exercise programs that are actually not getting our older adults stronger. And that is a huge issue that is coming into the fitness space. It's a huge issue that is also coming in to the rehab space. And it's something that Dustin and I have worked extremely hard over the last, oh my goodness, 5 to 7 years to try and combat these beliefs. And it's why we are so excited to be able to get onto discussions like this with fitness professionals, because we are both responsible for fixing this problem in our worlds. And so how bad is this problem? Dale Avers is like the geriatric queen of physical therapy. She has written our textbooks on geri PT. And she says, muscle weakness is related to decreased physical function in falls and is a compelling reason for physical therapy intervention. However, inadequate resistance is too often seen where clinics, whoops, sorry, I'm trying to have the chat box open and read this at the same time. It's not going very well. Where 2 pounds are commonly used and an arbitrary number of repetitions are given without a quantitative baseline assessment of strength. How many clients do you do a 1 rep max or an estimated 1 rep max test in? Probably not very many, and PTs are the same. And so strengthening without rationale or adequate stimulus is tantamount to malpractice. And that was a very, very strong sentiment, and one that I completely agree with. We need to be taking that. And so how does this relate back to this trajectory? What we know is that an adequately dosed, with progressive overload principles exercise program, specifically focusing on some of the big movement patterns, can increase a person's physical resiliency. And with that, it will translate into an increase in quality of life, a decreased risk profile for exacerbations of chronic disease, hospitalization, and serious adverse events. And it can reduce the risk of transition into long-term care. And so what we want to be able to do in the fitness space and in the rehab space is work together to optimize the amount of physical resiliency that our clients have so that they can do all of the things that they want to be able to do for as long as possible before their physical function dips below the line of the demand for their day-to-day tasks. And unfortunately, either individuals will become ill or transition into long-term care or skilled nursing facility becomes a reality. And the question then becomes, how do you identify if that person is in a 1 rep max living situation? For physical therapists that we speak to who are in home health, sometimes it's pretty easy to see what's going on. But if you're seeing them in a gym and you don't get insight, I'm a community dwelling, older adult, community dwelling physical therapist. So I see people in the clinic. So sometimes they can do really well in the snapshot of time that I'm assessing them, but really at home, they're in this situation. And so I have to have something that's gonna allow me to gain some insight into what's going on. But first we're gonna do some squats. All right. You ready? 30 seconds, sit to stand. Starting at 3, 2, 1, go. Make sure if you counted. Yes, Dustin's putting his screen on. I'm on a stool, so I have to make sure that I don't sit down. That would be bad if I fall on camera. Not surprising, but. All right, 20 seconds, 10 to go. Three, 2, 1, and time. Good, all right. Shake those muscles out. Good movement, snap. Reducing negative consequences of sedentary behavior, and here we go. All right, how do we know if a person is 1 rep max living? We have some questionnaires, which is really great. And so 1 rep max living, it's so much more sometimes than just the physical. We don't have the time to be talking about all the components of resiliency, but there's also things around mental health, emotional health, and isolation that definitely come into play when we're thinking about a person's vulnerability to external stressors. And so that's important. We have some psychosocial factors and outcome measures that we can use that have good literature to support them. We have the resilience scale, the Connor-Davidson resilience scale, and the Brief resilient coping scale. We also have measures of fatigability. Sometimes that 30 second sit to stand test even can be a test of fatigue. If you have a client who can do 2 in the first 10 seconds and then 1 more in the next 20 seconds, right? They're gonna be someone who's got low muscular endurance and is easily fatigable. And then things like a cardiac stress test kind of give you a good idea from an aerobic capacity perspective of how much reserve our client might have. What about when we're doing an evaluation? Oftentimes when you guys are seeing a new client, you're gonna do a thorough exam or interview with them. It may not be necessarily like a PT exam, but it's probably gonna have some outcome measures or some fitness tests that are gonna be really great to get an idea of what their capacity may be. But in the subjective, it's gonna tell you a lot. Like if they are having pain after, you know, walking to go get their mail at the end of their mailbox and their driveway is about 50 feet, then their resiliency is probably gonna be much lower than when your client comes in and is like, yeah, I went for a 2-hour bike ride and then the next day my back was just bugging me, right? So those are gonna be different things. When we're thinking about physical therapy though, oftentimes when we're not really thinking about physical resiliency, because the triggering event is that people are coming to see you because they're in pain. And the biggest fact that we have seen is that a pain is usually a manifestation of your body not being strong enough to handle what you're asking it to do. And what you're asking it to do may just be to do your laundry. And so what we are actually seeing is that the limiting factor is pain, but the reason why that pain is there is because of a lack of physical reserve. Yeah, and so the way that we present this information is going to be important, right? Like we have to address pain. We can't say, oh, well, we're just going to build your squat up and that's going to make your pain go away, and feel like we're dismissing an individual's complaints of pain. And if you're working in the fitness space, working with older adults, you're not going to get very many of your clients who are completely pain-free. They may be pain managed, and that's a whole other conversation. But oftentimes we're more concerned about building this capacity than some of our clients can be, especially for some of our physical therapists that we talk to who are having clients who are under required PT courses of care. And so Jeff Moore is our CEO at ICE, and he kind of did this podcast around how strong are you going to let me get you? How old do you think I am? And it was brilliant because it was talking about how, you know, it is so important and we need to get you as strong as we possibly can. And it is the only option. Like we need to try and push our clients to be as strong and resilient as possible. And so he did this podcast saying that there is a fire that has to be under our butt, especially for these clients who are teetering on the edge of independence, that we need to get that barbell in their hand. We need to get that dumbbell in their hand. We need to get that TheraBand or weighted vest in their hand and make sure that we're doing a progressive overload program. But I am very aware that that is not always going to be our clients' hopes and desires. You know, sometimes, probably not in the fitness space as much, because usually people are seeking out your services because they want to be healthy and active. But Atul Gawande, I don't know if you guys have ever read the book Being Mortal. It is an incredible nonfiction piece for the general public that's about end of life. And he has just some incredible insights around respecting a person's decision to choose their end of life and the trajectories that a lot of our older clients go to, and what the pros and cons of those are, and what some innovative models of healthy aging are. And he had this comment that was really wonderful. So in healthcare, our goal is safety, you know, reducing falls risk, survival, and health. We want to get them as strong as possible so they can do all these things, and we're big cheerleaders and you can do it. But their goal might be just to be able to read a book in silence. And that was really hard for me to come to terms with, because I am that cheerleader. I am that, like, you can do this. You can, I don't care if you're 75, like, we can get you strong and make that strong relative to you and all that kind of things. And you know, we have to be able to accept that there are going to be some people who just don't want to do that, and that is okay. And that is why in this quote, you can gradually lose some functions and have some issues along the way, and yet have great satisfaction in life. And so I think that's important to consider when we talk about this topic. All right, what are some other self-report measures that we can use? Again, when we're thinking about the safety piece, we're always looking at sometimes falls prevention. But sometimes we are pushing our clients further than they want to go. And that is because they have a fear of movement, a fear of falling. And what we are starting to see is that that can really significantly impact a person's resiliency as well. And some of these outcome measures that you can print off and give to your clients, and usually they can spark really great conversations, is the falls efficacy scale, which is a measure of fear or concern of falling. The activity specific balance confidence scale. I love this because it goes from really simple exercises like walking down your hallway in your home to really high level tasks like being able to walk on ice or walking onto an escalator. And then we have the patient specific functional scale, which is a quantification of activity limit and measures a person's confidence and essentially sets their own goals for their fitness routine. And what that would be is like, I want to be able to go, down my driveway when it's icy in the winter. How confident do you feel on a scale of 0 to 10 of being able to do that? 1. What do you think we need to do to get your confidence from a 1 to a 4? And then they say, well, I should probably be doing an exercise program, and I definitely need to work on my balance. And you're like, excellent, let me help you do that. Because what we see is that even all things being equal, if an individual has a fear of movement, which will definitely impact their resiliency because it's going to reduce the amount of times they perform tasks in their performance. It's going to decrease their activity level. So they're not going to do the things that they need to do. So they're going to start experiencing some of the negative soliloquy of sedentary behavior and lack of muscular strengthening. We see a decline in independence. They won't go out if it's snowing. They won't go out if it's raining. And what we see is that it translates into a reduction in their quality of life. And that's really important for our older clients. And so this is just one example, and there are countless studies that are looking at the impact of fear of falling on our older adults. And what this study showed was that really fear of falling impacts a person's postural control and their visual behavior. So I want to quickly go through this study. So my mom is a horrible highway driver. This is going to make sense why I'm kind of ripping on my mom. The reason why is because when she is driving on the highway, all she does is look at the nose of her car. What does that mean? It means that everything that comes into her field of view is very last second. It's very sudden, and she gets very afraid. This similar action occurs when your older adult client has a high fear of falling or fear of movement. So the photo on the right is a figure from the paper that we've cited on the bottom left of your screen. And this took individuals who were at low risk, had low fear of falling, were non-fallers, and then people who had high fear and had had a previous fall. And what they did was they got them to navigate across an obstacle course. So you can see the initial target, and then there's 2 obstacles that they wanted them to navigate. What you see in the graphs below is that individuals who had low risk and low fear of falling scanned their environment. You know, they weren't looking at the nose of their car, they were looking forward to see what was coming and planned out their movements appropriately. It also took them less time to navigate those obstacles. For individuals who had a high fear of falling, they were so focused on not letting their toe trip on that first obstacle that is what they fixated on. They spent an extra long period of time, they navigated through the obstacle course much slower, and visually they fixated on that movement. And that just shows, you know, extrapolate that out in terms of 1 rep max living. If this is a very fearful situation, which could be having to step down from a curb in order to get into their doctor's office or get back from their doctor's office, that could be something that would stop them from doing those things. And so it's really important for us to consider not just physically what their body is showing us that they're capable to do on some of these outcome measures, but also really deep dive into our subjective assessment and say, you know, what do you believe your capacity is? What are some of the barriers for you being able to do the things that you want to do? And if fear of movement or fear of falling is one of those things, let's have a conversation about that. Because what tends to happen is this cascade of activities where when we have individuals who have fear-related anxiety, we see huge changes in their movement patterns. We see that they focus really more on the internal cue of like, okay, how much do I have to lift my knee up before I'm able to clear that curb? They stiffen up because they're worried, right? That they're gonna be knocked over, which we know does a whole bunch of things. Like it reduces our safety and it actually makes our balance worse. And so all these things are going to be extremely important when we're thinking about how we are structuring these exercise programs for our clients. And sometimes it might not be that we're going to throw them into a full exercise program right away because they're afraid about some of the activities that might be involved. All right, but how do we go from the subjective to the screen? When we think about our screens and physical therapy, we think in terms of vital signs. So these are clinical measurements, specifically pulse rate, temperature, respiratory rate, their blood pressure. All of these are really indicative of essential body functions. And these kind of come into some of the red flags around individuals who may be inappropriate for exercise. They're not usually seen a ton in community dwelling older adults. We definitely see changes with exercise and pulse rate and respiration rate and blood pressure and all those types of things. But one of the things that we like to incorporate is a movement vital sign. And there's more and more literature showing that, you know, indications of physical function like gait speed is something that will be able to really be predictive of outcomes. Sorry, I'm gonna cough, my throat is dry. I don't have COVID, I promise. And so what we're trying to see is that, you know, we know that individuals who are walking at about 1 meter per second are probably going to be a pretty safe community ambulator. Individuals who are at 0.8 or lower are more likely to be homebound and are more likely to transition into skilled nursing facility, for example. And so we have this information and we can use it to really make an argument for why it's so important for us to be continuing to be active in the fitness and rehab space. Even activities like the timed up and go, which is standing up from a chair, walking 3 meters, turning around and sitting back down, can have endpoints that can be indicative of all-cause mortality. Slower timed up and go speed is associated with an increased risk of developing an MI, congestive heart failure, and all-cause mortality in older adults. So these are things that are showing that physical resiliency and these outputs of physical outcome measures are good markers of overall body health and body function. And it's something that we in the fitness and health space can do to try and reduce the burden on our healthcare systems, keep people healthier for longer. Same thing with grip strength. Grip strength in a lot of epidemiological studies, these longitudinal cohort studies with large amounts of people, is often used as an indirect marker of overall body strength. And what we see is that it's been associated with a lot of health outcomes. Higher grip strength was associated with lower risk of all-cause mortality and lower incidence of cardiovascular disease, respiratory disease, COPD, cancer and cancer subtypes. All of these things are such important indicators and just truly show that individuals who are stronger are harder to kill. Grip strength norms are under 26 kilos in men and under 16 kilos in women. And those are the cutoff scores for a condition called sarcopenia, which is a clinical geriatric syndrome that is essentially a clinical level of muscular weakness that is presenting with difficulties in completing day-to-day tasks. We also, in the fitness space, have a lot of physical fitness tests that we can use for some of our older adult clients that are extremely helpful in trying to stratify what risk category they may be in or what exercise modality is most appropriate for them getting started in a new program. We also have a falls prevention screen. We have the STEADY, the Stop Elderly Accidents, Deaths, and Injuries. The actual name for the acronym is kind of harsh, but the STEADY is being used a lot with physicians. So if you are able to look through the STEADY, you are going to see that these individuals, like if you start talking about this with a client's doctor, for example, they're going to be very aware of the STEADY and some of the outputs of the STEADY, which is great. All right, I'm going to give this to Dustin. What can we do? What can we do about 1 rep max living? No. Where is Dustin? Hey, Dustin. There we go. Beautiful. Momentary interlude.
All right, let's see here. Make sure I can see the Q&A, which I cannot. So you got that, Christina. That's okay. I think we have one question. If y'all have any other questions, let's take a second. We're about halfway, just have a space for some questions or conversation. So if you do have any questions, drop them in.
Yeah, so the question we had was Jenny and Beverly were asking about getting a copy of this presentation, and I believe it is being sent out. So yeah. I think
Lisa, can you speak to that? Is that like an extra paid option, or could you give them some?
I would think that attendees will be able to have access, but you know what? I know who to send a text to right now to find that out.
Okay.
And I'll put the answer in the chat. There's 20 chats and there's 2 Q&As. If you need some help with that, let me know.
We've answered the question, so we're good.
Perfect. Okay.
Yeah. And the chats are just me obnoxiously copy and pasting all the links that Christina references.
Awesome. Good. Okay.
All right. Any other thoughts, questions, concerns? And y'all feel free to type in that chat box. We love for these online presentations to be interactive. That's something that we really enjoy whenever we're doing our online courses or our live course, is that our goal is to walk away, where all of us walk away learning something, because we learn a ton from the people that we're speaking to, and hopefully you all learn a ton from us as well. But feel free to engage. Fitness test manual. I'm not sure if it's from Cal State Fullerton. It's been around for a while. Yeah, I'm not sure. If Christina may be able to look that up to see if it's from that one, but it's one that's been around for a while. The newer one that she referenced was the Senior Athlete Fitness Exam. And if you all were at the FAI summit last year, Becca Georgery had a presentation on that, and she runs that at the National Senior Games every year. Or was that maybe 2 years ago? Whenever that was, when we were in Albuquerque. So yeah, some good options there. Cal State, cool. All right. What can you do about 1 RM living? Well, one thing that we can do, oh man, is another 30-second sit to stand test. Oh, these suck, don't they? All right, let's go. Try and beat your last time. 30 seconds starts now. Go. Make sure I don't rip my earplugs out. Y'all didn't expect to be sore and out of breath after an online presentation, did you? All right, 10 more seconds. And 3, 2, 1, done. Ugh. Good work, everybody. We're getting there. Okay, so physical resilience in older adults, systematic review and development of an emerging construct. Now I'm out of breath. Christina, how'd you do that? You did like 2 or 3 of them. You just kept on rocking. I'm out of shape. So, so this paper, it is in the chat box. It's open access, meaning that anyone can read it. You don't have to pay for it. And it speaks really well to this. And so if we look at this graph, which it's kind of stretched out, so it's not the best quality, but it really kind of sums everything up, is that we have a natural stressor. So for some, it may be a difficult social situation. It may be a difficult relationship. It may be a natural stressor like the flu or COVID-19 or an injury or a fall or something along those lines. And so based on our physical resilience, which, you know, all these factors feed into that. So psychosocial factors, genetics, physiologic reserve, life experiences, and then our environmental factors, all of those contribute to our physical resilience, and that contributes to the outcome, which for some, and we're seeing this right now with COVID-19, is that they get that natural stressor, and based on their resilience, some people are hospitalized, some people are put on a ventilator, others, they get mild symptoms and they go on their way. And so we're really seeing this play out right now. Flu season, it's pretty commonly played out if anyone has been or spending time around an assisted living facility, skilled nursing facility. You see this every year, basically all the time. And so when you see these factors, I want you all to think about, what can you manipulate? What can you change? What can you, with your particular expertise and skills, what can you do? So I think about psychosocial factors, maybe some, not much, especially if you're like a home health therapist, like you have a unique window into people's lives, and you could potentially help them in that manner. Genetics, are we changing much in terms of genetics? That's a topic for debate. Some may say yes, others may say it's not significant. Life experiences, not much. The environment, potentially. But the big one is this one right here, physiologic reserve. That is our bread and butter, and that is what we can really do to increase capacity, like Christina talked about. So what we want to do, boom, get that line up as far away from this red line right here, as far away from it as possible. The more capacity, the more physical function someone has, the more reserve that they have, the more resilient they're going to be to a natural stressor. We want this laundry basket deadlift to be 30%, 20%, 10% of Gare Bear's max deadlift capacity. We don't want it to be 90% of what he's capable of. So that is our goal with many of the people that we work with. And I'd like your all's thoughts here. This is probably a pretty common experience, whether you're in fitness or rehabilitation. I keep looking to the left because this is where the chat box is that we know we want to get someone moving. We want them to exercise. And we say, all right, here's this plan. Here's these ACSM recommended guidelines. And you say, oh, well, Dustin, I'm already pretty active. I walk, you know, I walk every day. That's enough. Like that is good enough, you know, to help me be healthy and fit. and I'll be just fine. And that may be helpful, but typically when we look at the research on walking programs, is that it's kind of hit or miss in terms of how helpful walking actually is when we look at some of these very important measures related to quality of life and functional independence. So this was a 48-week walking program, a home-based walking program, looking at Falls Efficacy Scale, which we talked about before, the SPPB, which is a short physical performance battery. It's just a group of different tests looking at lower extremity strength, balance, gait speed, which is really important, falls, reported quality of life, and they had an objective measure of strength. So what did this walking program do for individuals? It was 386 people, 65 and up. This walking program showed that it did not really improve strength, which is going to be a pretty consistent theme in the literature, is that you're not necessarily going to get stronger just by walking. Balance, no significant improvement, or falls efficacy or quality of life. Now, don't take this as we're saying don't walk. Of course, we want people to walk. It's a vital skill, especially if we want people to be interactive in their community. But that may not be enough when we're trying to really increase people's physical capacity. Another common scenario is, Dustin, I'm active. I garden a lot. Type yes in the chat box if you've heard that one before, where someone claims that their gardening is going to basically equate to or replace the recommended exercise guidelines. I know I'll hear that a lot, is that I'm active, I garden. Christina is an active gardener, but I don't think Christina is meeting the ACSM exercise guidelines with her gardening. Are you, Christina? I mean, you've got like a homestead.
I do, but I wouldn't consider it my exercise.
Okay, all right, good answer, good answer. Yeah, so a lot of us can really relate to this sentiment. Well, wouldn't you know, there's actually someone that studies this stuff. Gardening activities and physical health among older adults, a review of the evidence. And Christina could speak to some of the numbers in terms of the cost of some of these studies, which is kind of interesting. I don't want to know how much it costs to put this study on, but it's a lot more than what you would think. And what they found is that the current literature does not provide sufficient evidence of the physical functioning consequences of gardening. Future studies should consider how specific gardening interventions help older adults meet physical activity guidelines. So once again, gardening is great. Obviously, I love it because a lot of times I would be able to reap the rewards of someone's hard work in terms of their produce. But in terms of physical functioning, when we look at some of these objective measures, we're not seeing a big change there. Yeah, Christina said some randomized controlled trials can be $10,000 to $50,000. Think about that. Expensive, very expensive. And then we do have our people where we try and tell them the benefits of exercise and movement, and they say, but Dustin, I exercise. And then what do you say? You say, well, what do you do? Or show me. And that is always a very interesting response. And I want to bring this up. I want to make sure, I don't know if my audio is going to share. Christina, let me know if you hear this audio.
No, I can't hear it.
You can't, okay.
But that's okay.
Yeah, that's not important for this one. So, just to give context, this video, seated exercise for older adults. If you go on YouTube right now and you search exercise older adults or exercise seniors, this is likely going to be the first hit or towards the top of that that review or the listing. This video, we came across this, well, I think this was last year, Christina. It was like just over 1 million views. And I didn't tell you this, Christina. We looked it up again this past weekend. We were teaching in Asheville, North Carolina. I think this is at 3.2 million views now.
Oh my goodness.
Yeah. So over the past year, since we've been talking about this, which, you know, we're not saying that we contributed to this at all, but they have tripled the views of this video. And it's scary because watch this and you'll see this is the evidence, or not the evidence, but the recommendations that's being put out there. Toe raises. We're going to do 10 repetitions And this is the whole video. It's 9 minutes long. He's doing, the person's counting the rep one by one, and look at this guy's face. Like, this says it all. He's almost falling asleep right here, folks. And this goes on for 8 more minutes. He does not crack a smile. The other important thing is that he does not get out of breath either. And this is the top hit on YouTube. Yeah, he's really sweating. Definitely at least moderate intensity exercise. That when some of the people that we may be working with, whether it's a patient, whether it's a client in the fitness profession, they go to YouTube, which a lot of people are, this is likely the first thing that they're going to see. That is scary, in my opinion, especially in the context of 1 rep max living. So we did toe raises, now we're going to do heel raises. And I'll save you all this. I mean, it goes on for much longer. If you want to watch it, you're more than welcome. It's rather interesting to see. So that's the current state of exercise when we're talking about older adults. And many of you are familiar with that. And we're trying to rewrite that narrative for sure, but we have a lot of work to do. So what can you do about 1 rep max living? Now, we are going to provide some practical advice, but also really think about your exercise prescription maybe in a different light. So we're going to talk about reframing risk, which is a big consideration or something that we think about a lot when we're trying to prescribe exercise to older adults. We want to become masters of scale, and we want to think about snacking versus feasting in terms of practical implementation to actually change people's behaviors. Using the same exercises warm up with partially or non-ambulatory patients, Hartman said. All right, so let's go to, and provide a little more context for that if you don't mind in the chat box, Hartman. All right, so reframing risk. We want to begin this conversation talking about the Hippocratic Oath. So type in yes in the chat box if you've heard about the Hippocratic Oath before. This is commonly, in medical school. I think it's around maybe the 2nd or 3rd year when they have their white coat ceremony that they take this Hippocratic Oath. There's a lot of physical therapy schools now that are taking kind of an adopted version of this oath, and there's a lot in there. It's really interesting to read. I encourage you to check it out. But there's also the statement of that they swear to do no harm. That they have a goal to not harm the people they're trying to serve. And that's rather interesting to think about when you kind of step back and think about these people that are trying to help people and save lives, that they have to take an oath to not harm individuals. And why is that? Why do they have to take an oath like that? Because there's something called iatrogenesis, from the Greek for brought forth by the healer. Sometimes you'll hear about iatrogenic causes if you've heard that before, but it's from the Greek for brought forth by the healer. This refers to any adverse effect on a person resulting from any activity from a healthcare professional promoting products or services as beneficial to health. The easy way to think about this is when helping hurts. When the helper is trying to help someone and you end up actually hurting them. This applies to people in healthcare and rehabilitation, fitness professionals as well, because we're all trying to serve older adults or our clients or patients, but sometimes our helping can actually hurt them. So what are some practical examples here that we see? One, which is rather, I would say rare, but I think many of us maybe have heard some of these horror stories where someone, let's say, is going in for a right knee replacement and then they leave with a left knee replacement. Or someone had some type of knee, shoulder, or some type of orthopedic surgery, and then they left the OR room with maybe a couple gauze pads and maybe some staples and some other implements from that surgery in terms of hardware that wasn't accounted for when they sewed them back up. This is when that surgery went wrong. The people did not have malintent. They were trying to help this person, but they ended up harming that individual. Another one is hospital or healthcare acquired infections. This is a picture of someone that has MRSA. But if you have interacted with any individual, I think especially this time frame that we're going, or the season that we're going into fall, winter, especially for those in rehabilitation, that you work with individuals and they may end up having some type of pneumonia, for example. They get admitted into a hospital, and then when they get discharged, they have pneumonia, and they may have a few other medical diagnoses and maybe some type of infection that they received in that facility that was trying to help them when helping hurts. Another big one is medications. How many of you all have worked with individuals that received a new medication for a particular issue that ultimately had a net negative on their quality of life? A big one that we are very familiar with and see a lot is the prescription of something like benzos, for example, where people are having maybe some type of mental health issue. They may be prescribed something along those lines that ultimately reduces their reaction timing that could increase their risk of falling. We also see this with diuretics as well. Different classes of medications that ultimately can increase the risk of falling or decrease people's performance to where it may improve that particular area that, you know, the prescribing physician was focused on. However, there are these net negative results, and we often get to see that firsthand. When helping hurts, this is a great example of that. And I think this is Dr. Tim Flynn. He's a physical therapist in Colorado, but this is where he says, never underestimate the power of the medical system to make you worse. So the helper can definitely hurt. There are lots of examples of this. And we want to start this conversation on exercise and reframing risk with that in mind. So the interesting thing about this topic of the emphasis of doing no harm is create an interesting discussion in the medical community. So do no harm unless doing no harm hurts. And so with the sole emphasis on absolutely eliminating risk, the end result may be that the interventions that we may choose to do or not do could actually help individuals. And so there may be some things that carry a little bit of risk that we may not even try because there may be just a little bit of risk that could cause harm to individuals. And so this is a great piece I encourage you to look at by Stephen Levine. This is in 2013, but these conversations are still going on, where he was saying that if your sole goal is to do no harm with individuals, that may be harming them as the end result because we're not willing to provide an intervention that has a minimal risk. And I think this is something that we need to think about as movement professionals or exercise professionals in our exercise prescription. So what happens when your primary objective is to do no harm? I think about a lot of the individuals that may have a diagnosis of osteoporosis, for example, someone that we may be very concerned about a fracture. Typically, we're concerned about a vertebral fracture, where we may not be doing a lot of flexion or bending. A common exercise we may avoid is a deadlift. What happens when our primary objective is to try and ensure 100% that we do no harm to this individual? And so this is right here. This is what happens. Christina alluded to this before, that these people have weakness, they have deconditioning, they have pain, they have stiffness, pounding at the door to threaten their independence. And what do we provide them? The adductor ball squeeze. And you could take that out and put ankle pump, you could put unweighted bridge, whatever activity. And we all have our own little exercise that we know is not going to harm an individual. But the issue is that it is likely underdosed and it likely doesn't even have a chance to make those people better. We are doing people a disservice because our primary pursuit, many of us, is that we want to do no harm. We may be actually doing more harm by going so soft and easy on individuals. And for those that didn't get the meme, this is a Cheeto, all right? Y'all are healthy. You probably don't know about Cheetos, but where I'm from, this is a pretty common snack. This Cheeto is basically the deadbolt lock for this door, if you didn't get that. It's an adductor ball squeeze. It ain't gonna do the job, folks. This adductor ball squeeze is not gonna be able to fight off the weakness, deconditioning, stiffness, and pain. So we often think of the risk of loading. I'll raise my hand. I think of this often. How could I potentially hurt this individual when I do hand in that kettlebell, dumbbell, barbell, whatever implement for resistance? But what we want you all to think about is what's at risk if we don't load. What's at risk if we don't load someone like Gare Bear? Think about the potential functional decline that's going to continue. Think about the continued dependence and with activities of daily living. Think about the continued decline in his physical activity levels and what we know that correlates to. What's at risk if we don't load? So we got to be very honest with ourselves and think through some of these scenarios. What has greater risk? The risk of functional decline from doing no harm. Think of that video that we watched. The risk of doing those toe raises, heel raises, long arc quads. He may do some little butt squeezes in there too, all while he's sitting. Think of the functional decline that's going to continue because he's not getting an adequate stimulus to promote change. On the other hand, think about the risk of injury from a perceived dangerous exercise. This is a trap bar right here. These are two 25s on either side. And this lady right here is doing a trap bar deadlift. There's a little bit of risk of injury. She may have a little back pain. She may have, some type of soreness, ache and pain at some point. However, we do know we're making her brutally strong. We're increasing her capacity. She's getting further away from that red line. And honestly, I would rather take a little bit of risk of injury than the risk of being so weak that you cannot maintain your independence. What has greater risk? Risk of functional decline from doing no harm, or the risk of perceived injury from what we think of as a dangerous exercise? And so that's why Jeff, in this amazing video that I encourage you all to save that link. If you go up in the chat box, I posted that earlier. That's why he can make the argument that it is our ethical duty to provide people the proper stimulus to promote change. Time is of the essence with many of these individuals that are 1 rep max living. From the surface, it may seem like just a normal situation. Gary Bear had some back pain. Gary Bear got out of back pain. He got discharged from physical therapy. We thought he went back to normal, but actually he went back at a much reduced capacity. That is an urgent situation. And it is our ethical duty to provide him enough stimulus to increase his capacity so he can get back to his previous level of function, but then beyond his previous level of function. And that is why I can make the argument in this video down here. This was, man, more than 2 years ago. That's crazy. The most dangerous exercise for older adults may be the ankle pump. I hate on ankle pumps all the time. It may have its proper place in exercise prescription, but how it is applied, especially in physical therapy, it's a dangerous exercise. But most of the clinicians that are applying it are thinking it's safe because they know they're not going to hurt someone by doing ankle pumps. But I'm going to sit here and scream from the mountaintops that you are hurting that person because you're leaving so much on the table for them to actually get better and adapt and get stronger and increase their capacity so they're not 1 rep max living. These are 2 good videos. I would watch Jeff's over mine any day. Check that link out. It's in the chat box. All right, so risk reward quadrant. So these are how we think about exercises. On the left is the risk on the y-axis, and on the x-axis is reward. All right, I got, 9 minutes left? Sorry, y'all. I get a little amped up. I spend a little too much time on this stuff. All right, so on the left, risk, high risk, low reward. Bottom right is low risk, high reward. So we're not going to necessarily criminalize a particular exercise. There's a right time and place for an exercise. So let's go through the ankle pump, for example. Ankle pump in certain situations, let's say Gare Bear, I could say that's a very risky exercise and low reward. It's high risk because I know I'm not going to promote much adaptation by using it, and it's a rather urgent situation. However, if I'm working with an individual that may be in the hospital or a skilled nursing facility, or someone that may be bound to their bed, that's a rather low risk activity and high reward. So the ankle pump is great for them. Let's do ankle pumps all day with those individuals. Great. Now the trap bar deadlift, someone has that diagnosis of osteoporosis. I'm worried about a vertebral fracture. They're not demonstrating great mechanics. They're changing their spinal position a lot during the movement. That may be a high risk, high reward exercise as compared to someone else that I'm not concerned about their mechanics or their form or their bone strength, that is a low risk and a very high reward. And we're going to do lots of those trap bar deadlifts. All right. So we're not criminalizing a particular exercise, even though, you may walk away hating ankle pumps. There's a right time and place for it, but we got to understand the risks of that exercise and then the reward as well. But many of you are still saying, yeah, right, whatever. You're not going to get your clients to do that. But we want to encourage you to really think about, they're already doing a lot of these activities. A squat with the barbell on the back, a back squat. A lot of people are already doing this movement by standing up and sitting down every day. People are already deadlifting. They're picking something up off the ground. People are already doing loaded carries. They're carrying their groceries. So we want to think about that. And the way we apply this to individuals is through scalability. Scalability is the big thing. We want to be masters of scale. So this is a quote from Greg Glassman, the former CEO of CrossFit. He had an interesting summer this year, but he has said some pretty amazing things, some pretty terrible things as well, but some amazing things in terms of older adults. The needs of an Olympic athlete and our grandparents differ by degree, not kind. One is looking for functional dominance. The other is functional competence. The needs of an Olympic athlete and our grandparents differ by degree, not kind. And that's what we want to think about. What is good for the professional athlete is also good for our grandparents or older adults. We just have to scale it to those individuals. So ways that we can scale it. We can scale it by volume. That's a very easy one, a very common one that we'll do. We can change the load, how much load we leverage, but also the position of the load. For example, if someone has a really irritable hip, for example, and they're not really tolerating that in range of their hip flexion, then we may want to load a squat in front of them, like a goblet squat, for example, because they're going to be able to maintain a more upright torso and not have to flex their hips as much. And that can be more tolerable for them. Things like that we can think about. Cognitive load we have to consider with many older adults. We can scale that. This is the most common one, range of motion. Shortening a movement so they can still perform it, but still loading them up. And that's what we may differ in opinion from some other professionals about this, but with many individuals that are 1 rep max living, that they need more capacity, that we are more likely to provide them load, even at a very reduced range of motion, than trying to work on improving the range of motion through that movement and not loading them up. Because the physiological response you get from lifting heavy things, even if it's a shortened range of motion, is very valuable, especially if time is of the essence. So with many of the individuals that we work with, especially on that frailty spectrum, they may do a squat where they're squatting to a 30-inch box or chair, for example, or a bed, but we're going to give them a solid in terms of kettlebell or dumbbell or some type of resistance, and they're going to perform that through a shortened range of motion. They get a great response from that. So range of motion is an easy way that we can manipulate. Speed is another one. The speed of the movement, slowing it down or making it faster, is something that we can manipulate. And so that's how we think about scaling different exercise and activities. And so, you know, a barbell back squat for us is in the same continuum as when someone is laying down and doing a leg press like you see down here. It's all the same movement. It's just scaling some of those different variables. And so if we view a squat on a continuum, then we can take this movement pattern and apply it to that individual that is right in front of us. So for some of us watching in a more acute setting, you may be hanging out here doing leg presses, maybe doing box or chair squats when they're holding on to a railing or a countertop. And for some of you all, you may be staying up here where you're really loading up a squat in different ways, doing full range of motion air squats, but it's all the same. We're applying this movement to that individual. Same thing with the deadlift, that we can manipulate some of these different variables. Same thing with a loaded carry, where we may be just holding a weight, standing still and not walking, versus some of you all may be leveraging more of a dynamic carry where they are walking and maybe holding it in a different position as well. All right, so we like to think of these movements on a continuum and scale it appropriately to that individual that we are working with. The third thing and the last thing, when we're trying to apply exercise prescription, when we're trying to get people away from that red line and not live near their 1 rep max, is to think about movement snacks versus movement feasts, snacking versus feasting. If you're familiar with the ACSM recommended guidelines, which I hope you are, they can be rather challenging to meet. Type in the chat box yes if you're meeting these recommended exercise guidelines. I would say some weeks I am, other weeks I'm not. 150 minutes of moderate intensity aerobic exercise, that's a good bit. Resistance training 2 times a week, I'm meeting that, but it needs to be a vigorous intensity. Those can be rather challenging for individuals. So we need to think about where they are in terms of the stages of change and also their familiarity with exercise. So if you're a rehabilitation professional, these ACSM guidelines are out of reach for many of the people that we work with initially. So we need to think about on-ramping them to get to that point, versus some of you all maybe in the fitness community that may be working with generally active individuals, that it may be more realistic for them to achieve that. So we want to think about that. Where are they in this stage? Pre-contemplation, contemplation, preparation, action, maintenance, because that's really going to dictate kind of where we come at this conversation. So how we like to present this is, for many individuals, when we talk about these evidence-based guidelines, they're way out of reach. It's impossible to get to that amount of volume and that frequency. And so we want to be able to break this up. Now, these are often presented with the exercise guidelines, and we talk about the aerobic piece or cardiovascular components. That's the first thing that people typically mention. And then they mention the volume, 150 minutes, 2 times a week of strength training. And what we want to really advocate for, that's going to probably be more realistic and increase your odds of implementation, is you focus more on the intensity, that we focus more on moderate intensity and vigorous intensity for resistance training, because that is more likely to actually allow someone to implement these activities, because it's very difficult to think of 150 minutes of aerobic activity when someone considers, or they are considered to be sedentary. That can be a big jump for individuals. However, we can get some pretty awesome responses and gains if we are really hitting on intensity as well. And the resistance training piece is huge. This is a great commentary on resistance exercise training as a primary countermeasure to age-related chronic disease. And their big argument here is that on the basis of this review, we propose that the promotion of resistance exercise should assume a more prominent position in exercise guidelines. We always talk about aerobic training first, and that's the big emphasis, but maybe we should reverse that. Maybe it should be resistance exercise training that we're pushing even harder, because that is what a lot of the literature is showing to improve some of these functional measures that equate to a better quality of life and function. And so we want to break things up. We want to make it relatable to these people to increase their odds to actually implement. So we may want to emphasize the resistance training piece first. So we may want to emphasize more of the intensity than trying to get that massive amount of volume. And so we may end up trying to break things up in steps to ultimately build to them meeting those ACSM guidelines. And for some of us, it honestly may start with something like body weight. It may not even be external load to help people get going. And body weight for a lot of individuals is shown to improve strength, but also hypertrophy as well. This is a really interesting study I encourage you all to check out. We don't have time right now, but you can look the title up in the slides. Very interesting results from body weight squat training alone in frail individuals. I'll save you that. So snacking versus feasting, intensity. Focus on intensity over the volume initially, then we can ramp up the volume, and that's probably more realistic for people. We want to create that plan with an individual, knowing what's realistic for them. The big thing, intensity, but then we also want to be progressive so we get to those ACSM recommended guidelines at some point in their journey. It doesn't have to happen right away. For the people in rehab, we know you have limited visits with individuals, but just think of it as a journey that hopefully by the end of the time that you are spending with people, that we can get as close to those guidelines as possible. So, boom, big takeaways. Some of your people, your patients or clients may be 1 rep max living. I don't care what setting you're in. You could have the community dwelling older adult that's walking in all happy and bright-eyed and bushy-tailed to the gym or your outpatient clinic. And if you don't objectively assess them with some of those things that Christina talked about, you're not going to know. You'll be surprised at some of the deficits people may be showing when you actually test them. Identify if people are at 1 rep max living. Test these individuals. Use those norms, and you'll get a good idea. And then do something about it. For the PTs or the rehab professionals, they may come to you for back pain, but their biggest issue may not be their back pain. It may be their physical capacity or their lack of strength. Address their back pain, but make sure you increase their capacity. And same thing for the fitness professionals. You want to really get people away from that red line. All right, so hit us up with any questions. You have our, I'm gonna stop sharing here. You have our contact info, our Instagram handles. If y'all are on Instagram, dustinjones.dpt, Christina is Christina_Prevett. Hit us up. If you have any questions right now or even later on, just shoot us a message. We'd love to conversate and keep this conversation going. If you, we gave the slides to FAI, so you should get access to those in some way, shape, or form. If you still have questions about those slides later on, you know where to find us. We'd love to answer any questions there.
Hey, Dustin, I did get some feedback from Celia a few minutes ago, and I put it in the chat that, yes, anything that you and Christina want to provide or have already provided is available. The recordings are available to anyone who bought the Plus package. So I think the participants will know what that is. Okay?
All right. Good deal. Thanks, y'all.
Is that it?
Yeah, can you post their IG info? Let's
Yes. Yes. Also, I don't know if everyone knows or not, but if you want to save the chat, then go to where it says message the 3 little dots, and there's an option to save the chat. So if there were links and things that you want to save, go ahead and grab them now. I'll give y'all a few minutes.
Cool.
So Dustin, thank you. Thank you, Christina. Great presentation.
Thanks, y'all. Appreciate it. It's good to chat with y'all. And yeah, let's keep it going. So feel free to hit us up.
Oh.
Yeah, absolutely. Message us with any other questions.
All right. Jam-packed day. How are you doing, Lisa? This is a lot to manage.
Yeah, they asked me like 2 days ago, and I always say yes and help them. I actually coach. I'm one of the mastermind coaches for the Functional Aging Institute. So I lightly work for Dan and Cody.
Yeah.
So pretty much if they need something, I say yes. And it's been a great experience. Yeah.
Awesome.
Good deal. Turned my business around, that's for sure.
Good. Good deal. Well, thanks for making this as smooth as butter.
You are so welcome. I don't mind hanging out here while they grab that chat. There's still about 19 participants, unless anybody still has questions.
I actually do have to head out. I have another patient that is currently waiting for me, but it was nice meeting you, and hopefully we'll be able to have, but there is one question by owner.
Yeah, by Joey.
Yeah, Joe, you want to type that in?
Oh, he can't, he's coming
Oh,
on
there he
here.
is. Okay, cool.
Okay, that's fine.
Oh, I just allowed him to talk.
Joey, you have the floor, but you probably need to unmute. Yeah, Joey, you're muted. Are you able to unmute?
While he's unmuting, Debbie asks, what's the best movement screen for clients who use a walker? That's a good question, Debbie. A lot of people that I work with or have worked with had a walker. The SPPB, that short physical performance battery, even though if they use a walker, that could still be a good glimpse into kind of where they're at in terms of their function. So I would look that up. Short physical performance battery test. Because some of the tests, they may need the walker, they may not. But that one was pretty applicable for a lot of individuals that will give you a score, a number that will kind of see how they're doing, and especially on that frailty spectrum. So you can find that right here, this instrument, link to that. But with someone that, Debbie, are you in rehab or are you fitness? Because I think depending on what you are, I think that's where like people that are in that situation where they're needing something like a walker to ambulate, that typically, there may be some other issues going on that may be rather medically complex. I think that's where fitness professionals and rehab professionals, when they work together, are so valuable to individuals like this. Because I imagine that individual that you're talking about, Debbie, has probably been on and off a physical therapy caseload throughout, the years, that if there is a solid relationship with the fitness professional to ease that transition of care to where someone gets discharged from PT and they're working there with Debbie right away. Like that is so valuable for individuals.
It looks like Joey's question came through.
Oh.
You see it? I can read it to you.
Yeah. Do you have a band there, Christina, or do you have to go? Best way to create load with bands for squat or deads?
Yeah, I don't have a band, and I do have to go shortly, but one of the things that you can do for deadlifts is to, if you have a TheraBand, you're gonna pretend that I have it, you're gonna loop it around your legs, and then for the deadlift, be able to stand up with it. That TheraBand deadlift, I actually also love working for individuals with low back pain because it's like an accommodating resistance. So as we get into a more forward flexed position, individuals are going to probably be a bit more fearful, be a bit more painful, and that is when tension is the lightest. And then as you stand up, tension gets harder, resistance gets more, and people feel like they're in a more comfy range of motion. So that is one. With squats, other than like a band facilitated external rotation cue for the glute, that's a good way of adding some. So you put the band around the knees and get them to push out to get a little bit more facilitation of glute. I don't use TheraBands a lot for squats, or doing Spanish squats would be the other one. Would be like putting it around a door handle or a rig and then putting it behind the knees and doing Spanish squats to put more emphasis on the quad. You still might need some resistance, but even that little bit of band resistance into max knee extension at the top range of the squat can help with that.
Yeah, the squats are hard. If you just have like a strip, it usually has to be pretty long. That I've had people that will put their feet underneath the TheraBand, like Christina was saying, and then they hold the rubber bands or the TheraBand or whatever it is and hold it and then basically bring them up kind of over their shoulder. So they're holding it like this, or in a front rack position too, and then being able to stand. It doesn't feel, it's kind of awkward for them. But if you have like a power band or monster band or whatever they're called, it has to be really thin where it's like the big loop, and you can put it around their feet, put it over their head where it's kind of resting around their neck, hold on to here, and then stand up. That can work with individuals, but it can be challenging to get, sometimes it can be too much resistance for individuals. So you'll want some options there, but deadlift's so much easier to load with a band than a squat for sure. Cool. All right, good stuff.
All right, we better wrap it up. I'm sure they're needing this room for another presenter.
Yeah. See y'all.
All right, guys. Good job. Thank you so much.